for 2 more minutes, then we can start the session. I hope we all read the terms of the TID earlier. It clearly outlined what the questions we asked in the last meeting that we had some time back. So in brief, Ryculture is dedicated to ensuring that you get sufficient skills that will also build you and ensure that you deliver as much as you can while you're impacting the different programs in your communities. And we hope that through this engagement, we'll train you and you'll also train others so that the more people get better information and the initiatives that we start or the initiatives that we're running become more successful. So without wasting much time, I want to welcome our partners, Maristops, our partners for Maristops Kenya. I don't know if Salima is around. She will give us an opening remark and introduce us to our program and launch it before we pass it on to Dr. David Odhiambo, who is from Ryculture. I'm not sure if Salima is in the meeting. Dr. David, could you confirm if she's around? Or if Salima is around, she could unmute and say hi.
I'm not seeing her around, but I can see Desmond is around. I don't know if Desmond, you could step in at this point.
Okay. We'll also welcome Mr. Desmond from Maristops Kenya. Desmond?
Yes, Desmond.
Hi, good morning, everyone. Hello.
Good morning, Desmond. We can hear you.
You can hear me?
Yes, we can, perfectly.
Oh, that's great. My name is Desmond Mwania from Maristops, Kenya, working with Maristops as a programs officer in charge of youth, gender and inclusion projects within Maristops. And welcome to this particular meeting. Salma was supposed to be joining you guys, but she's held up somewhere. She will be joining you guys in the course of the training. So mine is to welcome all of you into this particular training and encourage you for us to be ready to learn, share our thoughts on how best we can be able to work together towards ensuring that there is access to SRH services within our communities, then see how best we can join our hands together to form, to increase our synergy, to ensure that we are able to reach to more girls, to reach to more boys, and also to be youth advocates within the communities where we come from to ensure that we address all barriers which hinder our girls and also our boys and our girls who are between 15 to 24 years old from accessing SRH services within the communities where we come from. So our major objective of this particular training is that we had shared earlier with David was we are looking at strategic youth groups within the communities or within the counties where you're coming from, for us to be able to see how best we can be able to work with those youth groups and or the CBOs or youth champions for us to be able to increase our presence on the ground. And our major areas of focus is on advocacy, and also enhancing access to SRH services. And in the bit for the advocacy, we are looking at strategic partners at the counties so that wherever the counties are developing annual work plans, CIDPs, and also engaging in other key areas which and even the budgeting, the county budgeting, so that we may be able to have representatives within those counties where we can be able to sponsor one or two youth champions and go and speak. What do the youth require? What do the youth want? And how do they want it to be done? Why? Because at times we've realized we do make decisions about young people. We do make decisions about decisions surrounding programming, decisions are around budgeting. But at the end of the day, most of these programs, even within our organizations and even at the county level, you find, and even at the national level, we find those decisions really don't have any impact on the young people. And wherever those decisions, wherever the youths are included, then we are able to come up with sound programs, sound interventions, where because the youths feel involved, the youths are part of that process, and they feel like they own the entire program, and therefore that's why that's why we are asking, and that's why we came up with this particular program, for us to be able to see whether we can be able to have youth champions from different counties, so that we may be able to increase that synergy, and also have guys whom we can be able to call at any time and tell them, look, we are having this technical working group in this particular county. Sponsor that person and we go with them. They go and speak on behalf of people. Or we are at the national level, whereby we are engaging either the Minister of Education, the Minister of Gender, the Minister of Youth, also the Minister of Health. Then we sponsor that person, and the person is able to go and speak on behalf of youth, rather than Maristop speaking on behalf of the young people. That's why now that's why we call for this particular training. And this particular training is very key. Why? Because we need to empower you, so that you may know how best can you engage in terms to do with yes, how best can you be able, can you engage? You have the technical skills to communicate, the technical skills to share the knowledge which you have, and also the experience. And that's why we called you for this particular training. And from the training perspective, we are supposed to carry out this particular training for a period of approximately 1.5 months, every weekend from today. And we're going to have different sessions cutting across aspects of youth advocacy, programming, youth programming, the policies and guidelines which guide access to SRHR access, role of social media and social marketing in enhancing access to SRH services and products, and also rights, and how can the young people tap into these platforms to ensure that then young people are able to access services, and also enhancing in bridging the gap between access to SRH services, which we currently have. So thank you very much. Back to you, David.
Perfect. Thank you so much, Desmond. It's a pleasure to have you here. And so far, everyone, I see we have 26 participants who have joined the session, which is amazing. Though we are hoping to get more people, because in the initial phase, we had reviews of the different applications you guys made. From 300, we ended up with around 60. So that is good progress, and it shows that for you as young people who wanted to be part of the Sexual Reproductive Health Youth Champions Network, there is some work that you're doing. There's a way that at least you are committed to doing the work. That's why you're even able to document the experiences, to document the insights of what you are doing. And therefore, it makes it easier for us to collaboratively engage and see how we drive that agenda moving forward, and how we amplify our impact, how we create areas of synergy. And those areas of synergy are what is going to enable you as young people doing the work on the ground, as Ryculture on the end, doing the convening aspect on looking at how do we engage with you better. And at the same time, our partners, for example, at this particular moment, we're talking about Maristops, they have an interest and they have work they're doing on sexual reproductive health. And at the same time, the people who are users and people who are taking up these services are people in our communities, they are colleagues, they're young people, they're adults and all that. But at the end of the day, it is you who is closer to them. It is you who is part of that community. And therefore, by you being part of the network, you being able to identify the challenges, get the support in the different engagement forums, represent their perspectives with support from our partners and with support of some of the technical support that we're offering at this particular moment, it's going to enable us to achieve much more wins as a team, and achieve much more wins for the sexual reproductive health, for the communities we live in, for the people we serve, and help our organizations continue growing, because we have a direction, we have a strategic plan on how we are all getting there in a collaborative manner. And that is a very key important thing, because at that particular point, we acknowledge that all the work that we're doing is aligned to the Sustainable Development Goals. Partnerships and collaboration is goal number 17, and sexual reproductive health falls under the health pillar, that is SDG number 3. So already we have integrated 2 key SDGs in the work that we're doing on SRHR, and creating a collaborative environment where we can both work together, we can both achieve our successes and drive that moving forward. I think that is a very critical concept that we have to acknowledge, that we are past an era of competing. We are past an era of everybody focusing on what they want to do and sticking by that. We are in an era that we are working in a society where there are so many things that we can address. There are so many challenges that are there, and it's upon us now to identify what are the different strengths that each of our partners have that we can leverage on. What are the strengths of what are the challenges in our communities that our partners have access to those insights? Then how do we come together to address them? Because if every one of us is going to work on their own, we lack the areas of synergy, we lack a common voice that can help us address these challenges. And ultimately, the most important thing, we will lack the resources and the ability to execute. But by coming together, we have the power, we have the ability to leverage on other people's strengths and work together to create an amplified front that is going to enable us do that work. So I'm glad that Maristops was willing and proactive enough to engage with us and to support the training program that we're having on these. Then the next phases, as I've already mentioned in the terms of reference, there's so much work to be done, and this is just but the start of it. So what I'm going to do is just to take you through a brief on how the program structure would run. So just a background, Ryculture Health and Social Innovation is an organization that we founded in 2017. And in Ryculture, our focus is on improving access to quality healthcare services and helping build human capital. And in that account, anything to do with health. Currently, we have a focus on non-communicable diseases, sexual reproductive health, mental health, neglected tropical diseases, and health system strengthening. And in health system strengthening, we are looking at what are the overlying building blocks to improving access to healthcare services. So that is a scope on what we focus on. And now in this particular program, the Sexual Reproductive Health Youth Champions Network, our aim was, how do we bring young people who are working on challenges they've identified in communities? And this is something that we discussed in our initial meeting with all the 300 people before we did the reviews on the materials that you shared and selected a specific few. And under this program, the focus is on how do we equip you with a skill, leveraging on the capabilities of our partners that we're engaging with. After equipping you with the skills, we look at how do we build networks where you can leverage on the strengths and the capabilities of others. And then from there, we look at how do we mobilize resources and take advantage of opportunities that are existing in different environments and different platforms for us to continue driving this agenda. And therefore, this is a network that is supposed to run to perpetuity. And at the same time as it runs, it has ability to deliver impact in the different communities we work. And that is our focus on how we want the Reproductive Health Youth Champions Network to run. Then as we go moving forward, the key thing that you've all acknowledged is, from even the last meeting we had, we are working with either youth-led organizations or young people who have identified a problem. Even if you're doing it without an established organization, there's some of you that we gave a chance to work with us. And our hope is, by being part of the network, we're giving you an anchor. We are enabling you to do the work better. And Maristops, as our partners, have already come in to offer the trainings. Then the next bit would be, how proactive, how engaged are you in ensuring we deliver this mandate, that we achieve these goals that we want to achieve together, and that you follow through up to the end of this program to ensure that we are able to deliver on that. In terms of program structure, as I mentioned on the TORs, we have trainings. As Desmond mentioned, we are going to have 6 training sessions up to 20th of November, every Saturday from 9 to 11. And these are the 3 key topical areas: the introduction to SRHR, youth programming in SRHR, and social marketing in advancing access to SRHR services and products. That is under the training. Then post the training now, As Desmond was mentioning, engaging in county forums, national forums, ministerial organizations, steering committees. That is where now our advocacy and visibility component will be coming in. On our end as Reculture, we'll also be looking at how do we give spotlight the work that you're doing. Other than spotlighting the work that you're doing, help you engage in the different communities where you are. Then we foster the partnerships and collaboration and ultimately resource mobilization in terms of sponsorships. MSK is already engaged in looking at how will we sponsor you in some of the engagement forums that you can do that. That is a key bit. And then at the same time, we'll also be looking at how do we enable you, other than just specific forums, how do we enable you to continue doing the work you do in terms of resource mobilization and see how that works better. And already the first resource you're getting is through the skills and the knowledge that you're going to gain through this six session training program. So that is a very key bit. Then finally, the expectations of what we had, I believe you all have read the terms of reference, but there's no harm in highlighting it again. So a brief of your organization's work around an introduction, which you all did. That is why you're part of this training for a start. And one of the things we hope is that for you to be able to deliver on the next phase of work, you need to be trained. And that is why we have the trainings. So we at least expect that you'll attend 75% of the training sessions, which is 5 out of the 6 trainings. And I hope you all will follow through to the end of that. Then you need to document the learnings and report back within 7 days after the last session, a 2-page document per organization. So after we are done with the 6 training sessions, what are the key learning outcomes? What are the key insights that you've gained that are important for you in continuing the work that you're doing? And what are the components that you're going to apply in your work? So that we pick the learnings and also we get areas where there's room for improvement so that the next cohort, when we're moving forward, can get to learn from the challenges we had and make better improvements in the training program. So that would be key. Then the next thing is an application of the concepts in your organization's activities and work. If, for example, you are seconded to represent in a technical working group or a forum within the county, are you able to apply social marketing in your building your case and engaging the people? Are you able to apply the advocacy skills? If you're able to, that would be a win for us because we are not giving you the knowledge and the insights so that you can bank them and move on with life like nothing happened. The value of education is applying that knowledge in making a difference in other people's life and in the works that we're doing. So that is one of the expectations we have. Then onward, participate and engage in the ongoing activities that we'll be having. For example, the different county-related forums, when we're having national forums and all, we have maybe, let's say, a summit and related, then we expect you to be able to participate, to be able to engage with us and continue driving that agenda with us so that the value of the work that we started doesn't come to an end because we are at a point where people that we started engaging with did not follow through. And that was very critical in the initial phase where we looked at, are these people committed to doing the work? Are they able to document some of the work they're already doing? And are they willing to engage in the long term? And therefore that was critical. And I believe we're on the same page at this particular point in time. And that marks the end of the introduction. So the next phase would be on the trainings, and I'll hand it over back to you, Michelle, to take us through and guide us as we invite our speakers for the session. Michelle?
Okay. Yes. I hope you can hear me, David.
Yes, we can hear you. Yes, we can hear you.
Okay. So thank you for giving us a brief run through of the whole program. It's the main points that have come out is that we are all trying to collaborate to make a greater difference. Individually, we might not, we will impact some few people, but then we might not do it as much as if we come together and work together to improve SRHR services in Kenya. So just to repeat what has been said, this program will have 6 sessions. We hope that you will be able to attend 75% of them, after which you will receive a certificate of participation, and those who would have attended most of the sessions, that is 75% of them, will be able to engage with them and move forward with them as we try and implement some of the projects that Mr. Desmond has highlighted while he was going through the session. So without spending more time, Josephine, I've seen your question. I will answer it. Let's see. Can you please clarify on the expectation number 3? Maybe before we move forward, Dr. David, could you clarify that before I welcome the next speakers to take over the second part of the session?
Okay, let me just have a review on number 2. So documenting learning and report back within 7 days after the last session. What we expect of you is at the end of the training session, the 6-part training session, you'll have learned something. There are some new insights, there are some of the different concepts that have been shared that you'll be able to pick and see how you can apply them in your actual work. So can you report back on the lessons that you've learned on the whole training experience? We need you to do a recap of what have you learned, and you can actually start it from day 1 to day. At the end of this session, can you write, let's say, 2 paragraphs on some of the key learnings that you've gained that you think are important for your work and are key in driving the SRHR agenda in the different communities and the different places where we work. So if you're able to do that, then we compile it continuously so that after with the last session will be on 20th of November. After 20th of November, we'd give you up to the end of November, that is 30th of November, for you to have the report sent back to Ryculture, so that also helps us in building on the advocacy and visibility component. As this organization, what are the key learning points that you took up from there? And the next bit is also to guide us in terms of improving the training programs so that the next cohort that comes in will be able to use that insight in applying, doing the work, and getting a better training than what we started off with. So it's supposed to be a continuous program. I hope you answered, Josephine. So Michelle, you can take it up.
Okay, so thank you so much. We'll move straight into our second part of this session. We have officially launched the program. So on the second part of the sessions, our partners from Aristops Kenya will come in and provide the training. Today, the session will be the key areas that will be covered is definition of SRHR, components of SRHR, why SRHR, engaging men and boys in SRHR, and other areas that we highlighted from the program that we sent yesterday evening. So our speakers from the poster you can see on the screen are Mr. Josiah Mandaza and Letty Agan from Maristops Kenya. I've seen Letty in the meeting, so I'm hoping Miss a youth service provider and a clinical trainer in Maristops Kenya. She'll be taking us through the second part of the session, and we hope that Mr. Josiah Mandaza will also join us. He is a clinical trainer stroke supervisor also in Maristops Kenya. So maybe a few ground rules before we move into the second part of the session, and I hand over to Miss Letty. If you have any question, please type it into the chat box, or if you have any pending issue that has to be addressed, you can raise your hand and I could address it, or I could help you out as much as possible. Please, if you're facing any challenges, don't feel shy, you can reach out, and I hope that we'll have a fruitful session. Yeah, so Miss Letty again, I hope you're around. Maybe you could unmute and say hi.
Hello, good morning,
Letty.
everyone.
Good morning.
How are you?
I'm good. How are you doing?
I'm good too. I'm honored to participate in this session, and I hope it's going to be a very, very quite interactive session. And I'm hoping they're going to get takeaway messages that is able to enable them carry on their day-to-day duties to make us achieve these missions that we have ahead of us. Back to you.
Okay. So thank you so much. You can take over the session.
So, okay.
Hello.
I'm trying to project something on the screen. Just give me a time. Just give me 1 minute. So can you see what is on the screen?
Not yet, but I've given you the right to share.
Okay. So we can see what is on the screen, or it's not there.
Yes, we can see it.
Okay.
You can just have now put it on slideshow so that it's open and clear. And I can see Salima has also joined us. Maybe she could just say hi as you finalize on the presentation. Good.
It's there?
Yes, it's here.
Okay.
You can see it.
So I'm waiting for Salima.
Salima, if you're in a position to, maybe you could just say hi. Hello.
Morning, everyone. My name is
Morning.
Salima Mohammed. I'm from Maristops, Kenya. Apologies for joining in late. Welcome to the training and look forward to sharing information and knowledge and skills on the work that Maristops is currently doing with regards to youth and sexual reproductive health rights. We also look forward to learning from you and all the work the great work that you're doing in the different communities, setups that you're in, and see how we can work together and collaborate together. So thank you for this.
Thank you so much, Salima. It's a pleasure to have you here. So I'll give it back to you, Leti, to continue on the training bit.
So thank you. Just as we had gone through, we are going to go through the definition components of the sexual reproductive health rights and why is sexual reproductive health right very important, how we are going to engage men and boys in sexual reproductive health rights, and then the role of COCs in sexual reproductive health and roles of youth champion in enhancing the sexual reproductive health right. So we start by definition of sexual reproductive health, right? So we start by sexual reproductive health. And as from the screen, it's a state of physical, mental, social well-being in relation to sexuality. I know sexuality is quite a broad term that if I would want to go deeply into sexuality, you're going to come through a lot of various terms. And then it is not merely the absence of disease, dysfunction, or deformity. And sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasure and safe sex experience, free of coercion, discrimination, violence. So for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. So we take note of, it should be free from coercion, no discrimination, no violation of someone's right. And it should be in a way that we must be respecting that person, and that person should be protected and be fulfilled. And then we have the reproductive health. And this is a state of complete physical, mental, social being, and not merely the absence of disease or infirmity in all matters relating to reproductive system, its functions and the process. So sexual reproductive health right, go to the third one, is the exercise of control over one's sexual and reproductive health linked to human rights, and includes the right to reproductive health as a component of overall health through the life cycle for both men and women. Because sex entails both men and women, although there are gender deviations which also have to be included in the sexual reproductive health. So the reproductive health decision making, including it should be voluntary choice in marriage, where someone is not supposed to be defiled in being raped by the partner. So it should be a voluntary choice. And normally there's a training we go through, like when you want to engage with sex, when you want to engage in sexual activity, all the partners must be comfortable to engage in that sexual activity. Can you force someone to have a cup of coffee? There are different stages of where you ask that person, do you need coffee? And the person tells you no, or can tell you, I want coffee. Yes, you can go and make that coffee. But the time of serving this coffee, the person tells you, I don't want coffee. Are you going to force that coffee into that person's throat? or the next moment you find that person has lost consciousness, will you still force that person to take that cup of coffee? So it should be a voluntary choice, even in marriage, and not necessary, not those in marriage. So family formation, determination of the partner should be able to have, in terms of family formation, they should be able to determine the number, timing, and spacing of the children they want to have, right to access informations and means needed to exercise voluntary choice. There should be quality and quality for men and women to enable individuals make free and informed choices in all spheres of life. Freedom from discrimination based on gender and sexual, reproductive, and health security, including freedom from sexual violence, coercion, and the right of privacy. And as you're going to go through this session, we're going to realize various ways of how people's sexual rights are being violated. I have examples from various countries on a report I went through on ICPD. So let us move to the next session and look at the components of sexual reproductive health. We have the autonomy, that is the right of a woman to make a decision concerning her fertility and sexuality free, and comprises of the following. There has to be confidentiality, informed consent, dignity, privacy, availability of alternative methods. Currently, we are facing a challenge in the country where there are some methods that are not available. As much as women want to make that choice of whatever method they want to have to plan or space their birth, or they feel they don't want to have kids anymore. So we found that the cost of having these procedures like BTL or vasectomy in the men's side, they have to take it as at a fee. There are situations where they're only given, like in a country like Botswana, they had a situation where they're not even in Botswana, in Mexico, where women had only 2 alternatives for contraceptive they would take. And this was sterilization, we call it BTL, bilateral tubal ligation in women, and IUD. So you find that it's either you had to make those choices, and it had to be in a situation where at a gunpoint, you have to take that IUD. So you see, this one is actually violating someone's right, and this person didn't get that opportunity to consent for that service. You're being forced to take it. So it should be autonomy where the woman makes the right concerning her fertility and sexuality freedom. And they should be given information, the right information, the side effects of this method they want to take, and be able to do the consenting in written where the document can be made reference to. And then we have the equality. The second bulletin is the equality, discrimination, and difference. There should be no discrimination against women through recognition and enjoyment, irrespective of their marital status, on the basis of equality of women and men, of human rights and fundamental freedom in political, economical, social, cultural, civil, and other fields. So when you look at political, how can women's rights be violated, or how do we discrimination when it comes to political? When it comes to allocating government resources, you find that women, the reproductive sexual part is the one affecting women the most, because we have to carry pregnancy for a whole 9 months. You have to attend to this clinic. We have to be attended by a skilled birth qualified person. And sometimes you don't feel it. You get pregnant, and you find in cases of rape cases, someone wants to terminate a pregnancy. How does the political element judge us? How does the economical aspect? Do we have the resources within our locally where we are living, the government facilities where qualified staffs are trained, where we can access these services? We look at the legal aspect of it. Does the law protect women to be able to make a decision in relation to their sexual reproductive health? And we find that if a woman does not want to carry on with the pregnancy, if the law does not protect this woman will resort to backstreet abortion. And at the end of it, they'll come with hemorrhage, sepsis, and then this lead to mortality or morbidity or even mortality cases. And here we lead to loss of life. So this political, economical, social, how are women regarded in our society? Is our rights in relation to, is sexual reproductive health attached to just the womb we are carrying, and after it, there's nothing more to it? Do we have a right to decide, I don't want to have this baby, I'm not ready? And then the cultural aspect to a woman's position in the society. you find that even in our today, a woman cannot just come. You teach the woman all the types of contraceptives, the long term, the short term. But the woman will tell you, no, wait, I have to go and consult my husband. Even as much as she feels you've given her the right information that this method will be the best for you, but she still has to go and consult the husband. So it's only upon when the husband accepts you can take these methods when this woman comes here and tell you the husband. So if the husband does not accept, this woman cannot give to this method. So we really have to look at the political, economical, social, cultural, civil, or any other fields. And then the right of life. It is the government's obligation under international human rights instrument to provide access to affordable quality health services that will prevent maternal mortality. And this one also come to lawmakers, allocation of resources, which should lead to reach to the marginalized area, hard to reach community. So that one leads us to the next. So I've taken through 3 components. There's autonomy, there's equality, discrimination. It should be non-discrimination. There should not be any difference. And then the right to life. And then the next one, we look at a woman's right to reproductive autonomy is often impaired because of her status in the society. Enjoyment of this right depends on a right to act as an independent adult of full legal capacity to participate in civil society and to be free from discrimination in various forms. I look at a scenario where the former kind of employment, if a woman seeks for employment, within the first 3 months of probation, this woman is not supposed to be pregnant. And you find even in certain countries, women are forced to do pregnancy tests on monthly basis to just be certain they're not pregnant, or even to worse even situation, they have to show sanitary pads on monthly basis to the nurse attached, the nurse employed in that facility, just to ascertain they're not pregnant or not, or their contracts are going to be terminated. And the worst scenario I've ever had in an institution I used to work, I'm sorry, I'm not going to mention the name. I had a friend who was just employed and she was pregnant. And within those 3 months of employment, it's indicated on the contract letter, you are not supposed to be pregnant. So there are some investigations, there are some medical investigations they do. And one of them is a pregnancy test. So this lady was pregnant and she was desperately in need of this job. So she asked me for an advice what to do. I told her, oh, well, you can take someone's pregnant, take it to the lab, let them do. And then in turns negative, you'll be end of your probation. And the trick worked for her. Not only to know at a time of delivery where she felt she had all the rights to deliver in that hospital, to access the insurance policy that the company gives to the employers. After undergoing a cesarean session at that cost in that facility, she was expecting the insurance to cover. And she was told, hey, you know, as per your employment terms, you're not supposed to be pregnant by now. You're not supposed to be having a baby now. So we are sorry, you have to pay the employment bill, and the contract was terminated. So these are some of the elements you're seeing women's rights being violated in relation to their reproductive health. And then so without the right to reproductive choice, all other human rights, civil, political, economical, and social have only limited power to advance the well-being of women. So making human rights to sexual and reproductive health pertinent in diverse ways to policymakers, program designers, and providers. So they have the right to absolute in sense that they must be taken in consideration and balanced against other interests. So actually, just to take you, I jumped a slide on other components of sexual reproductive health. So we had the reproductive choice on abortion. So on abortion, the laws should not discriminalize health service that only women need, whether aimed at the person who provides the service or the woman who is receiving it. So when you look at the law on abortion, the legal part of it states that abortion can only be procured when there's a quote they put, when the life of the mother is at risk or yeah, something like that. So in some way, this law is not protecting this woman fully that she can procure that abortion. And even to the service provider, the healthcare worker who wants to assist this woman procure this service in a safe, medicalized way. feels she's not safe, she or he is not safe to offer this service, and even this woman. There's a country that is, is it still in Botswana, where a woman was raped. There are laws clause that are saying if it's a rape case, you know, rape case now, there's a lot of mental, other things that might be involved. So the woman might not want to keep this pregnancy. So the legal element gives the woman the right to prosecute in case of this, in these situations. But are there procedures of how to do this thing in a legal way? So we find that this woman was raped, and they had to initiate a procedural court case, I mean. So by the time of finalizing this court case to allow this woman to safely procure this abortion in a legal contest, the woman was already delivered 1 month. So we find how their laws are there, but they're still not that helpful to the women. And then we have the reproductive choice. Do they have the choice to access the family planning stroke contraceptive? Family planning is those who are married. Contraceptives is those ones who are not already in committed relationships. So women should have the right to choose whether or not to produce, which includes right to decide whether to carry or terminate unwanted pregnancy, and the right of choice to their preferred method of contraceptives and family planning. So in a situation where the law is there, the law states that adolescent, this one, let me narrow it down to adolescent. Adolescents should have the right to access sexual reproductive health services, information, and the right to choose. And you find in a country, the law states that these contraceptives will be issued out in a subsidized price. Then at the same time, it's not really mandatory to give these adolescents this sexual reproductive health. If they come for contraceptives, it's not really mandatory to give them. And we're basing our assumption that they are not sexually active. And then at the end of the reports we are getting is that the percentage of adolescents between the age of 15 to 19, 85% of them are HIV positive. They've procured backstore abortion. And then how do we make these policies just right and in a way that they can understand without compromising ourselves when implementing such policies? So these are the things we really need to become aware, look into them, and even do more research, how we feel as much as this one is there, what could be compromising these other elements. We find adolescents coming to access these services. Adolescents who is the age of 15, let me say below 18, she has acknowledged she's sexually active and she wants to complete school. As much as their comprehensive sexual education curriculum being carried in the community, these adolescents who want to access these services, the law states that they have to be consented for. So there has to be an adult present who is above 18, that is the legal age, to consent on their behalf. So to some extent, I feel like their privacy, confidentiality is being breached at the same time, based on the law that we are having. So we really need to look into that when we are looking into these rights. And then the informed consent. Informed consent should be in a way that the woman is explained to the method that she wants. You take her through the side effects. You take her through the advantages and disadvantages. Let her understand the other optional methods that she can choose. In a situation where you only have 2 options for this woman, and this woman feels none of them is comfortable for her, is for informed consent going to be done? Because informed consent where she has to sign, I have accepted, and this one can protect even a service provider legally when you offer these services. And the client is able to feel satisfied, and she's able also to make referral to this facility, like, hey, I got a youth-friendly service provider that took me through all this, and I was able to make a decision of my choice. And the woman is able to complete using that method as the stipulated period of the method she chose. So in the informed consent, there has to be a wide range of methods available. Not in a situation where you go to a facility, you're being told you only have the 3-monthly injection. And in this 3-monthly injection, there are always a lot of activities that take place in our society. We have to go for burials, and that we find in the midst of it, we forget we're supposed to go for a return date. And we end up getting unplanned pregnancy. And then what next? Procure abortion, because you didn't plan for that pregnancy. So there should be a wide range of methods. That is the long term. Those ones who want permanent, they should be available for them, and they should be accessible. So that the woman has to walk for kilometers to reach these services. And then the information, they have to be given information. Sometimes we just tell them, we have this, the mom comes, Muko Nagani, I have this. You give her, you don't give her information, whatever you're giving her, what is it? How long is it supposed to take? What could be the side effects? How should she manage them? When should she come back to the facility? Mostly we don't do that. And then education and duty of care. As a staff in Maristop, we have a duty of care where service provider have to sign that duty of care, that you're going to give that client the quality of care, and it has to be a client-centered. Let the client make the choice, follow the right procedures, standard operating procedures as per MSI guidelines to offer these services the client is coming to assess. And then we have equality before the law. There has to be adequate legal procedures to ensure women enjoy their legal rights. Where ground for laws on abortions exists. If the law exists in that land, are there legal procedures, or not like in the case of this Botswana, this lady that was raped, she wanted to terminate the pregnancy. When she took the legal procedure, she was only approved to procure abortion when she had already delivered 1 month post-delivery, is when now the law approves that she can now procure that abortion. Are those laws effective? And then we have women in the vulnerable situations. What do we look in when we're looking at these women in the vulnerable situation? And they include the women in the rural and marginalized urban groups. So women in situations of armed conflicts. Just the other day, there was conflict in Barimbe and all that. Did we ever check the welfare of these women for them to access these reproductive services? Or when there's conflict, we only measure on how we are going to resolve those conflicts. When it's done, we forget women. And women are a backbone to this economy. Then the prostitution. In Mexico, apparently that document had these Mexico and Botswana scenarios, and even other countries that I think I've forgotten. So for Mexico, they used to carry these messages when they're around these dens where there's this prostitution activity. That is where now they carry this information they carry those banners, they write those things on those streets. So it's like these women feel like they're vulnerable. Their rights are not respected. But at the end of the day, we really have to accept prostitution is an old profession, and it's going nowhere. And we have to accept these women. We have to support them, because all this deals with sexual reproductive health. Otherwise, if you don't respect them, they go through sexual violation, they're being tortured, mental harm through rape and other forms of violence. And they're also susceptible to sexually transmitted disease, which is also in relation to reproductive health. And so we really need to look into their rights. Unwanted pregnancies. If we just always judge them, we go to those streets and judge them. We've cornered those streets, we've tagged them as Koinange. We can't, even when they come to our facility to access these services, we even know them. When they leave the room, we discuss them. Privacy is compromised. They have the rights to be respected. They have the right to be served just like any other person. So I'd gone through the human rights. Why do we feel these rights are very important? And as I had read, a woman's right to reproductive autonomy is often impaired because of her status in the society. Enjoyment of this right depends on her rights to act as an independent individual of full legal capacity to participate in society and to be free from discrimination in various forms. I'm happy in the county I'm working in, the governor has a program called Linda Mama. Women are supported through antenatal care up to where they get to make a decision concerning family planning or contraception. And Maristop organization is partnering with the Ministry of Health to train health workers to be competent to offer these services and not to refer them to Maristop. We empower them with skills, knowledge. We do vicar training to change their attitude in relation to sexual reproductive health. So that if we reach the marginal dispensaries, we're able to empower them with streets, and these women within this community are able to access these services at their own convenience. And then without the right to productive choice, and take note, without the right to reproductive choice, all other human rights, civil, political, economical, and social, have only limited power to advance the well-being of women. Making human rights to sexual and reproductive health pertinent in diverse ways to policymakers, program designers, and providers. Where we find situations where we do not allocate enough resources for maternal, this is all in relation to reproductive health, because reproductive health starts from reproduction, contraception, and all these. We find that when we don't offer these quality maternal health services, then these women are going to resort to traditional birth attendants. And you know, there they feel it's comfortable, they can pay this thing at this, they can pay this traditional birth attendants at their convenient way, and they feel at home because delivery is done at home. But not in an hospital setup. If anything goes wrong, in situation of breach, where the woman, the baby comes with the rears, not like normal with the normal head, is this traditional birth attendants, does she have those skills to attend these deliveries? Or we're going to end up with complications, and then we lose these women just because the government did not allocate enough resources to cover maternal child health care, which all sum up to reproductive healthcare services. So policymakers, the laws that you make in relation to abortions, do they favor women? Are there procedures in place? And the providers, do they have enough training? Do they have VCAT training to check on their attitudes towards the services they're giving women? And not to be biased, impacting their values on women who come to access these services, telling them, ma'am, you know, I don't have time to offer these long-term services. Let me give you this short-term because it's very easy. And also based on the workload they're having. And then the rights to absolute in the sense that they must be taken in consideration and balanced against other interests. Where we feel reproductive health is not very important. And the backbone, as just said, the backbone of this economy as women. The time when the government or the international board decided to invest in women, to look into women's health, the economy has quietly improved. And women are able to, they're able to space the birth, they're able to support their spouse, to support them in educating their children. It's not like the olden times where we have large pieces of land and having many babies to get a cheap source of labor used to be the order of the day. Now things have changed. You have to seek for white-collar job. And seeking for white-collar job, you cannot afford to have a baby every year. You will be a liability to the employer. Your health is going to be deteriorated because whenever a woman gives birth, our health deteriorates to a certain percentage. So we should balance this thing when we are planning. Let there be availability of those contraceptives, programs that support women achieve their reproductive health rights. So what are the roles of youth champions? Youths can greatly enhance the reach, attractiveness, relevance, effectiveness. When I was doing a project on we're doing a project Maristop on ideas. We're doing the live prototype of youth. And we realized that for us to engage the youth, we had to use the youths themselves. We had to get to know what do they think. And whatever project that you're trying to implement, is it relevant to them? How effective can it be to them? And this was only successful when the youths were involved to spearhead this activity. And this was a human-centered approach that was very successful. So the other one is their involvement increased legitimacy, acceptance, and influence amongst community members. We find that if youths are engaged, it increases their legitimacy, acceptance, and influence among other community members. Right now, it's the youths that are running community-based organizations, and there's a huge impact, evidence on some research that have been done. And then when we engage the youths, we're able to see their values, and they're able to gain their values. In fact, we enhance their values, because values, you gain them from we start building on our values from the age of 3. And this is reflected on our morals. Our values, morals, and decision-making should be in line. And this one enables them to gain confidence, that enables them to make them influence others. Because when we look at the percentage of youths in the community, we have a huge percentage of youths. So engaging them will reach a huge percentage. And then they're able to voice their needs, realities, and opinion in their own way. And then they're flexible enough. So their flexibility enhances that they're able to reach more vulnerable communities that had communicated, that I shared in the previous slides, the vulnerable communities. And then more youths can be reached with information through digital platforms, such as WhatsApps, Twitters, and Instagrams. So any questions? That's the end of my presentation. Any question?
Yes, any of you who has questions, anywhere you need clarification, please feel free to ask them. You can use the chat box as already had been mentioned by Michelle. And if you want to speak up, you can also raise your hand and we give you the opportunity to.
I can see John Bugwa has raised up his hand. You can unmute and speak.
Good morning. Hello, can you hear me?
Yes, go ahead. We can hear you.
Yeah, that was a very wonderful presentation. But I had one question. When Madame was presenting, I heard from onset that we should engage men in the conversation of SRHR. But in her presentation, especially why we need sexual reproductive health rights, all the points were targeted to women. Now, how do we bring in the conversation of women, of men involvement? Well, even the lane of our discussion, we leave out men. That is my question.
So, thank you, John Bugwa, for the insight you put. So we need boys and men engagement. Let's look at the setup of adolescents. They also go through these stages of, we look at the stages of growth and development in adolescence. And you find that the boys are left out. So when we were doing the CRC, the comprehensive sexual education in Trans Nzoia that Maristop was rolling out, which was being funded by Bill and Melinda Gates, there had to be male involvement, boys, that is. You have to make them aware of their sexual reproductive health. How can it affect their peers when they start engaging in this sexual activity? Do we educate them on the importance of sexual reproductive health. What are the pros and cons of engaging in early sexual activities? And how best can they support their colleagues in school? And there we had those, when we were going through those sessions, we had the sections on values, behaviors, and decision-making. These entailed all boys and girls. What values do you have? How do they make your decision-making? At this age, there are quite a lot of hormonal activities taking place in their body that dictate them to sexual activity. But yet they also have to make a decision. If I start engaging in this sexual activity, what could be the consequences? So by taking them through all this session, this is where they form relationship. And this situation, we have the healthy and unhealthy relationships. And unhealthy relationships is where you don't respect someone's right. You don't listen to them. There are a lot of things that we look at in unhealthy relationship, even in our current marriages. Do we make them aware of this unhealthy and healthy relationship and how they can support each other? So by doing this, we empower them with all these skills that are able to support each other to generate a productive people in the society. Now, when you look at productive people in the society, now the men in the society, do they help their partners make choices in relation to reproductive health? Or they feel like you just go to the facility by yourself, choose a method. And currently, let's just take it like it's not easy to make a decision for a man to use a contraceptive. They always leave this decision for women. Because at the end of the day, they feel they have nothing to lose. And we take a scenario of purchasing a condom in a supermarket. I'm seeing a lot of videos on social medias, Facebook especially, how a boy goes to purchase condom. There's a lot of just difficulties people accessing this condom. And so I always ask the teenagers, boys, how do you bargain with your partner? You need to use a condom. And they feel even them accessing this condom is hard for them. How do we support them? If we teach them the right way, if we teach fathers the right way to start this conversation in relation to sexual reproductive health, then we are going to support these rights in a very remarkable way. So as your question been answered, so by engaging them, let's start this through the comprehensive sexual education. In the society, do they support men? Do they support women to attend this antenatal visit? Do they take them do delivery when they're going for their delivery? Do they support them through all this support, these processes? So that is why we need to engage boys and girls. Boys through comprehensive sexual education and these other community. Men support our women when it comes to this. And even those professionals in these legal areas, let's not just women, let's support women. Men also support us in this formulation, policy formulation and all this. Otherwise, thank you.
Thank you so much, Letty. And I think also to add on that, maybe we could look at it from the perspective of, we already have the work that we're doing on sexual reproductive health. It starts from people as young people, let's say from this particular forum, we have young people working in the different communities with different organizations. Yes. By taking the first active role, you've already started engaging men. Because if I see a man engaging in sexual reproductive health advocacy, I'd be more willing to hear what does he have to do about it. Because the notion as it is mostly it's about women looking at for their contraceptive materials and related sexual reproductive health related materials. But what if we can also play a role and actively be part of the conversation? And it starts from menstrual hygiene management. I remember a while back, there's a menstrual hygiene management program that we had at Gashororo Primary School in Juja. When we had this conversation, the common narrative had been partners, organizations would be coming to the school, but then instead of talking to all the students, they're going to talk to the ladies. But when these ladies have their menses and their periods and all, it's the very boys who are not empowered who will be shaming them about periods and soiling their clothes. So what do we do to ensure that the men and the boys in these classes acknowledge that this is a normal biological, physiological process? so that they don't shame them. And instead of shaming them, they be willing to even work within the school to ensure they can have access to sanitary materials, to supply them, to be there to cover up for their friends and ensure they find a solution. And that would be the key approach. So let's start by, what are we doing as men? Then what are the different challenges our ladies are having, and what are the challenges that we as men, we can support them in addressing? Then once we move from that perspective, we'd look at it from menstrual hygiene management, contraceptive use. What are contraceptives that are available for men? What are the options that are available for women? Which one is the most ideal for the both of us, so that we have a relationship where none of us is actually go to unfairly balanced, in the sense that if at all we don't use any contraceptive, the lady will get pregnant. And if she gets pregnant, chances are, as a man, I'll run away and let her carry the pregnancy. Is that what we want? Would you want the same for your sister? If not the case, then what can you do as a man in that kind of a setup to ensure that we have more men actively and meaningfully engaged in sexual reproductive health related discourse and find the solutions to them? I think that would be key as well.
Thank you very much.
Yeah. I think there was another question. Michelle, you can follow through. I see there's another question that we're having in the chat, where Josephine is asking on, is comprehensive sexual reproduction part of component of SRHR? And how can we advocate for comprehensive sexual education, especially in schools? I don't know, Letty, if you have something on that.
I'll bring in Salma.
Okay.
Okay. Is Salma in?
Yes, she is. Let me get to unmute her. So Salma, you can now unmute yourself.
Thank you, David. Sorry, please repeat that question so that I can answer.
So is comprehensive sexual education part of component of SRHR, and how can we advocate for comprehensive sexual education in schools?
So comprehensive sexual education is part of SRHR, and currently there's a caucus in Kenya. I know there are various organizations that work on comprehensive sexual education. So what we are working on as Maristops, we are part of a caucus on comprehensive sexual education, and we are working to ensure that the voices of different people are heard right from community level. So we use the opportunity to get information and through our work and share our experiences. So as Maristops, we share our experiences, what we are seeing on the ground, and we provide this information to the caucus, where they're able to now build into policy at Ministry of Education and Ministry of Health. Currently, AMREF is leading discussions, AMREF are the lead discussions with Ministry of Education to review their policy on provision of age-appropriate comprehensive sexuality education. And this is a process that's ongoing. I don't know if that answers the question. So it's an ongoing process. It's not something that we'll just do and say that's the end of it, but there's engagement going on with both ministries to get them to work together.
Thank you for that. And I think that is, I remember last year there was a discussion on how comprehensive sexual education would be integrated in our curriculums. However much there are still some kind of cold feet, some people are not receptive as much. We have to acknowledge that these are challenges we're having as a society. Failing to talk about them, we're still going to deal with the burden. So what can we do to make that happen? So I think those are also areas of advocacy for young people and for people who actually know the implications and the impact. We've had classmates who got pregnant in school and they had to take breaks from school. How does that impact their well-being and their personal development? If we can use such cases from our own experiences from the communities we operate in, we can help advance that as well. I think that would be good for us to think of that from that perspective. And thank you for that, Salima. Then another question that I see is coming here. There was another question, it was sent earlier. Which is the best way to talk to men and boys to accept reproductive health matters in their adolescents and women? Some men hinder their wives from taking modern family planning methods. And parents do not accept their adolescents to take up family planning methods. And how do we go about that for them to see the importance and know it is their right. Any of us has feedback on that? Salima, yes?
So what I'll say, male involvement is also a process. And for me, what I would say is let's work within the already existing community structures. We have, through community health volunteers, their dialogue days, and through these sessions, then share why is it important? Share the importance. Don't just we can't go into communities and tell them women have to be allowed to use contraceptives. Women have, adolescents have to be allowed to use contraceptive, but what is the reasoning behind it? What is the advantage for these men? What is the advantage to the parents? As Kenyans, we always want to see, what am I getting out of it? So how do we show these men and the parents of the young people that there's something to gain from them allowing their wives or their daughters to access contraceptive services?
Hope you answered, Josephine. And it's clear, as Salima has mentioned, the fact that you look at what do they get out of it? What is the benefit they stand to gain by having the ladies and the women use the contraceptive methods that are available? For the men, it's helping you manage your finances, because at the end of the day, if that lady gets pregnant, it will be you to take care of that responsibility. And if it's not you, it means you'll be leaving that lady to struggle with that, to bringing a child that they wouldn't have if you did the right thing and you are responsible enough. So it's a matter of fostering responsibility and looking at what is the incentive for this other person to do the right thing, and then communicate it in a way that makes them want to take part and be supportive of that kind of an approach. Because probably they are going against it because of their own reasons. Do you get to understand why they're against contraceptive use? Then once you understand it and you told them the benefits of it, then you make it even more convincing for them to consider, well, I had these reservations, but then from the information that has been shared, there are alternatives, and there's a better way for me to approach these whole discussions. So I think that would be also important for us. Then there's a question on religion. How will religious leaders be involved in SRHR, because it's an issue in churches? And on that, I see there's already some responses, but I'll give you Leti and Salima to support as well. There's Mudhoni saying, in my case, our pastor encourages us to incorporate life skills in teen classes. And in that process, they open up and I address the SRH matters as they arise. They can offer counseling by maybe hiring counselors to educate the church or congregation. So those are some of the suggestions that have been given. And I don't know if you've done any related projects, Leti and Salima, on this, engaging religious leaders.
So at one point, I was getting a lot of resistance from the religious leaders. It's because, you know, religion, what it states or stipulates is like you have to maintain virginity until you only start engaging in sex when you're married. So that is still the whatever they have in the church. But you know, times are changing. And you know, the church, they don't offer these how do we call them? They don't offer mentor these adolescents with the right information and all this. So you find that there was a gap. And at one point when I started involving them, in that they're the ones to offer me the venue in their church, they mobilize their youths. And through those sharing experience with the youth, what others have gone through, they're able to be enlightened and see there's much need for this sexual reproductive health being given to adolescents. Because as if we want to bury our head in the sand and just assume the religious way is the way to go, things are turning upside down. So we, after talking to them, they had to embrace incorporating this sexual reproductive health in their programs. And they used to create time again for me to interact with their teens.
Okay.
Yeah.
Engaging with them and making them see the need in the community level.
Yes.
Yeah. And I see there's another response, Mudhoni, Komau. In my case, some religions like the Catholics are against family planning. What can we do to convince them that family planning is not bad? And then Leila is responding that nowadays most priests engage themselves in projects within the community, as I have been informed about family planning. I don't know if you have any additional comments on that, especially in specific religions where there are reservations and they have actually a church stand on what they can do and what they can't do. Especially on contraceptives, like this example of Catholics.
Anyone wants to step in relation to that?
Yeah, maybe I can just give a comment.
Yeah.
From some of the observations that I've seen as well. I believe that there are religions that most of us, religious trained teaching and practices, there's a reservation to talk about sexual health matters and sex generally as a concept, as a topic by itself. So therefore, because of that, as African culture, we refrain from talking about sex, and that makes it even more acceptable that churches would not talk about sex as much. So that would become a common narrative in these settings. But then now with the Catholic sector, the Catholic as a religion by itself, they have their reservations, which is true. But then the question for me would be, do we have a church in isolation? Because I believe the church is part of an ecosystem, part of a society and a community. Yeah. And we all, first of all, to acknowledge that it is the stand of the church, but then we have this church representing people and supporting individuals. I know some of very Catholic churches that are offering, they have orphanages, they have shelters for ladies who have been actually teen mothers and all that. And at the same time, some of these kids are not having the best of experiences in these places because the resources are constrained and limited. So I think we could look at it, if we are going to engage them, it will and it has to take time for them to get the buy-in. And you know the Catholic structure, if we're talking about Catholicism specifically, there are structures up to Rome. And for you to convince a pastor in Kenya to change the approach that they're taking, it has to get buy-in up to the end of the Pope. So in that case, it has to take time. But we need to look at it from these people. Yes, we can go through the church, try convince them, even if they're not endorsing, let them not be against. That is a first win that can be for us as young people and the members of the community, because if they're not opposing, if they give us room to engage with members of the church without them having a reference of the church said no to this. The church doesn't have to say a thing, but we can do it at that particular level that now we're engaging them and educating them on what needs to be done and how it can be done better. Then other than that now, when that becomes the norm, we can take advantage of the prevailing ecosystems and platforms within our community. Churches might not, let's say a church will not allow us to have the sessions there, but we have schools within the same environment. Can we use those schools? And I believe that most of our teachers are willing and receptive to such programs. The church is not against, but you're taking advantage of schools that are there to educate them. The community-based organizations are the ones that you guys are running. How many young people do you engage them with? Are they willing to come and talk to you about this? So that it becomes a societal narrative on how do we help our ladies and our communities to be more receptive and responsive to sexual reproductive health related matters, and acknowledging that there are limitations within some platforms and some institutions that are serving as barricades. So therefore, we just lessen those barriers. And that is how we can approach, let's say, the churches which are not pro-contraceptives and related.
So also what worked for us when we were rolling the comprehensive sexual education in Trans Nzoia in 2019, schools were recruited, and amongst them, a committee was formed where schools were to be recruited. And amongst some of those schools were Catholic schools. And after taking the heads through what CSE entailed, there was a lot of controversy on section 3 of our curriculum, where there was contraceptives use. And I think the priest that was chairing the Catholic schools that had been selected lobbied in for the schools to be withdrawn from the program. And so it happened enough that the schools that we were left with, there was the head teachers, the GNC teachers were able to note the positive impact. Although there were two or three Catholic schools that still went head on. And from the outcomes of the heads of those schools, they're actually able to acknowledge that that program had some positive, even if it was not that huge, but there was a slight positive impact of that project in their schools. And you see, this one is unable to get a buy-in from other schools, and they say, hey, if as we went head on with this program and there's a positive impact in relation to reduction in teenage pregnancy and even dropout in relation to teenage pregnancy and cases that relate to adolescents, disciplinary cases in relation to sexuality and all that. So we were seeing the visibility of some still buying in for allowing us to go back to their schools. And then also if those ones that were not able to reach in school based on the verdicts that they are put, they don't want that program in the school, we were able to reach them through community. And through community, they're able to impact others individually in their own way, based on what they learned through the session. So one man's poison is another one's what? Food. Yeah. Thank you.
Thank you so much, Letty. I don't know if this question has been answered, but Grace has asked in the chat box, are there any other contraceptives for men except vasectomy? Maybe something like an injection or something from your experience?
No, for now, as much as research are being done in those Western countries, for now in our country, we only have the male condoms, vasectomy, the natural method of withdrawal, which is not applicable amongst the youths.
Yeah, I can confirm from the pharmacy perspective, we've not had any breakthroughs in that area, but we're hoping there would be a chance. Not assured, but hopeful. And that is why now, knowing that men are not much engaged as such and there are fewer solutions for men, then we need to look at how do we engage them to promote the uptake of these contraceptive methods among ladies and women in our environment. Because if they don't, the repercussions are there and most of them are not going to take them up. So yeah. I think Rogers Omolo had a question. Rogers, you can speak up.
There's also a question.
Thanks so much. It's indeed true that young people are in digital platforms because I've seen like their digital like Facebook Live, we have Twitter, and even those digital platforms, we have the toll-free numbers that young people do call. But now the question is on the impact. How do we measure impact on this digital platform? Because if we assume that young people are on digital spaces and we don't know the impact, how do we measure the impact of young people being engaged on matters SRHR on digital spaces?
I don't know, Letty, do you have a response to that, or I can come in first?
You come in, I'll throw it to you.
Okay. Okay, thank you. So one of the things, as you've mentioned, Rogers, most young people are on digital platforms and they're using these digital solutions to access their sexual reproductive health information. In measuring impact, the key thing for us for a start is, why do we have these digital platforms in the first place? If, for example, currently as Ryculture, we put in place, let's say, a chatbot, and that chatbot is to give sexual reproductive health information to young people, then our impact would be how many people have engaged with that platform. Because when we look at the project implementation matrix, we would start from the inputs. Then after inputs, we have the output, we have the outcomes, and we have the impact of the work. So being that we've designed, let's say we've designed a digital solution, we'll be looking at it from how much, what resources and what was our intent at the start of the program. Output, we want to give information to young people. How many young people over a period of time have used this platform, and how engaging have the conversations been? They need sexual reproductive health materials, we refer them to where they can access them. They need access to services in terms of, let's say, for example, implants and all. These are clinical services that has to be offered by institutions. Have we referred them? Then after that, the outcome of that referral, the outcome of use of that information would be the next thing. After the output, we move to the outcome. For those who've referred to a particular institution, how many of them have made the move and gone to those institutions to get the services? Then that would be an outcome. We referred 10 ladies to a particular health facility X, and they got the contraceptive method that they wanted. It's an IUD, the hormonal injections and all that, whichever it is that they wanted. Out of 10 we referred, 8 of them went for the services and actually got the services that they needed. Then the impact will be now in the last mile of it. We're talking about, let's say, access to contraceptive methods. They're taking contraceptive methods, teen pregnancies have reduced. Well, let's say, for example, it's in the same community, we had an average of 5 out of 10 ladies getting pregnant over a period of time. But by being able to offer this information, which referred them to institutions where they could get services, we are now having 2 out of 10 or even 1 out of 10 only, instead of the standard 5 or 6. That is an impact because we have less teen pregnancies, more ladies can continue with education, and that means we are making a difference or making an impact. So it would be a system-wide approach. What are the immediate outputs? What is the outcome of this service we're offering in the next phase? Then what is the intended outcome? Reduced teen pregnancies, reduced rates of sexually transmitted infections, and all that matrix. So we have to look at the different facets of it. And when we talk about the youth platforms as well, the other digital platforms, Twitter, Facebook, and all, those are kind of crowdsourcing information platforms, social networks. So there's no specific structure on how it is, but you need to ask yourself, how many people are engaging with our content? Are they applying that content in their own environments? We might not get the actual feedback on, well, let's say, for example, we do, after this session, I know most of you are engaging the different social media platforms. You can engage with us, you can share some of the insights you're getting. You'll see people will check that information. You might not definitely know that this person is using it in this manner, but the level of engagement can help you assess on how many people you've informed, the reach, the engagement, and the insights that have been gained. So that would be a key measurement. But at the end of the day, in terms of the impact, having a structured engagement where you see how many people are we reaching through these platforms, how many of them are being converted, and how many of them are actually taking up the services that we're encouraging them to take up. I think I'll give it at that. I don't know if you've been answered, Rogers. Okay, I think now if you answer that would be good, then we'll have the question. Yeah, perfect. Thank you. If Juma, you can unmute.
Okay, thank you very much. That was a wonderful presentation. Just have a quick one. That what does the WHO guidelines says in terms of the consent age in respect to accessing the contraceptive services?
Consent age or?
Of the consent age of accessing family planning services to young girls, the minimum consent age. At what age can a girl access the services without parental consent? As per the WHO.
Can you support on that?
So I don't know if you're able to allow me to share the policy the current policy we have on sexual reproductive health.
Sure, you can share. Let me just
the right.
Yes, let me stop sharing so that you can share.
So I'm on.
Yes, you are on. You can share.
It's on the screen.
Not yet.
How do I make this? Oh. So maybe there's a policy 2015 adolescents, National Adolescent Sexual Reproductive Health Policy that entails all the rights on in terms of consenting, when to give an adolescent, SRH policies, and the clause that you have to consider. So the age of consenting as per the national laws is that 18 and above can do a consent. But if an adolescent under the age of 18, they have to have a guardian or someone who is above the legal age. So let's take a scenario of a 15-year-old who comes for contraceptive. And she acknowledges, she informs you that she's already sexually active and she feels she needs a contraceptive. A health worker, are you going to deny these adolescents these contraceptives based on the fact that their policy states that they have they cannot consent? So in this situation, either this minor, we call the minor, can come with no, sorry, I had the legal whatever. Just a minute. I can share it through the, can I share it on, because I can't project it on the screen? But
So
if they're able to download that policy, National Adolescent Sexual Reproductive Health Policy, 2015.
Okay. Actually, what you could do after the session, you could share some of the materials, and we'll share with all the participants for review and follow-up.
I think if
consent is the age.
yeah, so if they're able to go through that, they're able to understand and gain more insight in relation to that. Back to you.
Okay, thank you. So Michelle is going to share a link for the feedback form, as we've said, so that we respond to it and share some of the best lessons we've learned from today, some of the things that we can improve on and how to go about that. So Michelle, you can go ahead. And as you do that, I'm still trying to read some of the comments. Oh, yeah, here it is.
So the policy is there.
Yes, we can see it.
You can see it.
Yeah.
So if you look at those principles in that policy, there's respect to human rights, fundamental freedom, there's all that. And then there's where just get where that. But it's a whole huge document that someone really needs to go through.
Yeah.
Yeah. The heading, let me just go scroll where the heading. I can click page 1. Sorry.
As Letty goes through that, some of the things that we also have to acknowledge, as there's a case that she was mentioning in the form, that there are certain cases that somebody would need services. And we all know there are some of people who are not within the age bracket to be allowed to give consent and procure these services by themselves. But the question is, at what point do you deny them access? And at what point do you give them that access to the services? And then how do you enable their communities to be responsive? Because one of the things is, we are in an African setting. If a young lady, let's say a 12-year-old or 13, 14-year-old, went to their parents to tell them that they want to use contraceptives, the first thing would be, are you having sex at this young age? So the repercussions would make that such a person not want to even mention the fact that they want to get the contraceptives. So how can you enlighten the parents and the communities from where these ladies operate to see that the best thing we can do is accept that this is a fact, this is the reality. People are having sexual intercourse at an early age than what we expect, than what we would be made to think is the standard time that we should. So how do we ensure that they don't suffer the consequences by not accepting that fact that is there with us in our community? So those are some of the dynamics that we also need to factor.
So as you check on the screen, we look at number 5 on the acknowledgement. The 5, they have the Adolescent Sexual Reproductive Health Policy Framework. So if you go through that area, you're able to get more information on the questions that you're having. And then we also had scenarios of where a service provider has been sued by a parent of a minor, a 15-year-old, where the minor came to the facility to access a contraceptive services because she's sexually active, and she had even acquired a birth abortion once. So she felt like she doesn't want to go through all that procedure again. So she resorted to taking a contraceptive. The health worker offered the contraceptive. And you see some of the methods are visible. The minors cannot hide it. So one of the parents saw it and went to the facility, and the health worker, the nurse, was summoned. And you see, these are some legal things that when the health worker was asked, did the minor consent for that service? But you see, the legal framework states that someone who is below 18 cannot consent. Consenting can only be done by someone who is over 18. So in some certain situation, you'd ask the minor to come with a friend or a relative who is above the legal age, where you do the counseling, you explain to them, and let that person above the legal age consent on behalf of the minor. Secondly, if the minor cannot come with a relative or a friend above the legal age, then a health worker within that facility can be a witness when consenting, so that it doesn't look like the healthcare worker coerced. And then the consenting has to be documented. You've explained to the minor, and also that person to explain to the minor in in an understanding manner. Those, the medical terms are quite technical. So they should be interpreted to the minor in a language that she's able to understand. That is the side effects, the side effects and those other things. So when it's documented, then you're covered by the law.
Perfect.
Yeah.
Thank you for that. You can continue filling the form that has been shared by Michelle on the meeting room, the chat through box as well. That is the forms, that the GLE and all that. There's a link that is there. Steve Juma, I see you still have something as you gave us that feedback.
Yes.
Yes.
Just in response, latest response.
Yes.
Based on that, I just wanted to get the interpretation of Article 43 that guarantees everyone access to highest attainable standard of health, which in that case that hasn't specified with the age. Then also on issues of confidentiality, privacy and confidentiality, because seeking a contraceptive service that is a health thing and requires a confidentiality, whereas we now introduce a witness and maybe for consent or as hormone as a parent, as breach of confidentiality appears here. What can be the interpretation of confidentiality, the Article 43, and now what the policy says? Is there somewhere that has a gap?
Give a response. First things that we have to acknowledge is there are different gray areas in terms of policies and governance frameworks, and that is why there's so much focus on how do we streamline the policies and framework. That is rule number one. In terms of confidentiality, there is confidentiality and there's the legal ability at the point when we're talking about the consent and assent. Consent is somebody above 18. Anybody less than 18, the provision is that in terms of the legal counsel and legal understanding is this person doesn't have the intellectual capability to decide on what they want and what they don't want. And therefore, there's need to have a senior person who is believed to be to have their best interests at heart to represent them. That is what the law provides for. So those are some of the dynamics of what does confidentiality start and where does it end when we're talking about access to health services that this person would need. And then the dynamics of societies where we exist in as well have to be factored. And the reason as to why I've just projected this screen is that actually Article 48, as you've mentioned, and all these other policies are falling into the next program that we're supposed to have on 6th of November, where we'll be looking at youth programming in SRHR, looking at laws, policies, treaties, and the Constitution of Kenya on provision of adolescent sexual reproductive health services and products. So at that particular forum, we'd be more keen on what does the Article 48 provide for? Everybody should have access to the highest quality, the highest quality of healthcare services, including sexual reproductive health services. Then if that is the provision, then at what point do we consider that they have access? When they have contraceptive services, when they get the health education, health promotion services, and all the other services. And then within the SRH space, how feasible is it for them to access these services that they need? And what are the barriers? We can talk about the barriers in terms of when we have the policy that is making them not be able to give consent by themselves at a younger age, then that is kind of a barrier in a situation where the parent actually is not willing to give that assent on their behalf. So how do we bridge this kind of dynamics in a society now where we put the Article 48 provisions for access to quality healthcare services and other guiding principle frameworks and policies that are supposed to support, but they might be hindering that access, and look at how do we make it be workable in this context where we are operating in it, specific to that context. For some of the societies where we operate, there are people whose mothers can take them even to get the contraceptives at 10 years of age, 11 years. But there are people who, even when you are an adult, 20 years of age, you can just do it because it is you as an adult who is able to give consent. But it doesn't mean that your parent is accepting or even willing to encourage you to go for it. So how do we bridge that balance? So I think that is one thing that we'll consider in that session on 6th November. And we have very able trainers for that particular session that first ask someone, Paul Musumba, who will guide it. And I hope that helps. So I'll take a moment to read the comments that we have on the chat so that we don't leave out anything as you continue filling the rest of the form. And in this, we start from Jocelyn. We've also engaged myself in training religious leaders, but right in the rural community, and some religions are resistant. In towns, so most religious leaders are coming to understanding of this, but rural is still a matter. There are still churches that still do not allow their congregants to attend health facility when they are sick, so it is a concern. So those are now the religious practices, and that is where we now talk at the socio-cultural dynamics. And the socio-cultural dynamics are important, and that is one advantage that you all have to acknowledge. We have the benefit of working with young people within the communities. You understand the challenges in your community. You understand the influencers. What if you are the key opinion leader, the key access point or point of entry in that community? If you go talk to your chief who knows you to be supporting young people, they are more willing to engage. But if I, as David, come to your community or Mary Stops comes to the community, they'll already have a prejudice that these people are bringing their notions, their ideas. But you are part of that community, you understand it better, and you can solve it from a point of understanding what their perspectives are and what needs to happen in that environment. So those are some of the things that we need to know. How do we access these communities? How do we change their thinking? And how do we support the movement? So that is key. Then age of adolescence require parental consent. That one we've talked about first. And we'll talk more about it again as we move forward. Then some parents and even healthcare workers will deny the adolescents and use the right to access reproductive health services because they feel their sexual activity is unacceptable. That is now another thing that we need to look at in terms of the consent and the social dynamics.
So just to add on that,
yes,
this is where now Maristop does a value VCAT training on value clarification. Mm-hmm. And the value clarification entails where they are taken through training where they don't have to impact their values and morals. Mm-hmm. Because we are brought up with different values. And remember, our values change based on circumstances we face. When we grow up, when you're growing up, we are being told you are not supposed to engage in sex until we are married. But you find that some circumstances such as poverty forces a girl to be engaged with a boda just to get that an extra coin, to get a sanitary towel, save her from long distance of walking to school and back. And so you get, the values keep on changing. And we don't have to impact our values on them, but just accept them the way they are, give them the right information, let them make their choice on their own.
Perfect. And if you are being told that you have to wait to have sex when you're married, what about those who don't get married? Or rather, and even those who don't want to get married? So it's a whole dynamic of things that we need to consider it.
There's something I've seen on the screen where someone is asking about the law and they are 14 and 15 years old who are already married at that age. And at that age, an adolescent is not supposed to be, they're supposed to be in school. So you find that you find that even the kind of legal frameworks that we are having do not support this system, because you find that adolescents are already married, you want to make intervention. Because when they already get pregnant and you find that whoever impregnate them is above law, of which this is a defilement. But when you want to take up this legal process, the cost of taking up this legal, and mostly it's always those marginalized areas. And then the kind of community structures that we are having, where some parents even use their daughters to get how do we call it? They set up their daughter in a way that the daughter is going to lure someone, the daughter gets pregnant, they take this case to local legal system within the communities, like the chief, the community health, the kangaroo courts we have in the community. And then they get to be paid a sum of like 40,000 or 50. In this 40 or 50,000, everyone has their own percentage. So see, it's sometimes it's always hard to crack these things that even sometimes it's just their own way of doing things. In certain situations, even taking up these legal cases, going to file for this thing, the transport from the marginal areas to the major referral hospitals where they can access this document and this thing is done. So they're being told, them getting that transport to that facility to fill those documents, and even paying that one, in a certain area, they were paying 1,000 to whoever who is filling that form. They don't have that 1,000. So you find most of the time these cases end up not being reported. Most of them end up being married at a very young age. They don't get to meet their dreams. So we also, this legal framework, there's really much, a lot to be done in supporting.
I totally agree with you. There's so much work to be done. And as much as there's that work to be done, we have a role to look at them from within the context that we operate in. If you're saying consent is after 18, but what happens when I'm married off at 14? And the very people who are talking of me not accessing contraceptive services are the very people marrying me off and actually negotiating my dowry at that point. So
and just an interesting example is one principal summoned me to the school why I served, and there's a mine I served with a contraceptive, a 16 years old in class 7. So the girl eloped for 2 days. And so the principal was looking for me. I'm the one who gave that contraceptive, and it's like I was encouraging this minor to engage in sexual behaviors. And so I presented myself to the principal and I asked him what could be the problem. And he told me, you are the ones who are encouraging these adolescents to engage in early sexual activity. And I asked him, currently, what is the statistics of pregnancy cases in your school? And he comfortably said 6 are pregnant. So I asked him, you wanted this one to be the 7th one. And what, within your capacity, what action have you taken against, because this one you're dealing with 6 defilement cases, which is a major case. And you're looking at this one, this only single one, that I was able to arrest the situation. What have you done to these 6? Have you reported the cases? Has a follow-up been done? And he just went mute. He couldn't say anything. Yeah.
Those are the dynamics. So as we are going forward, we need to see how do we address the challenges within those contexts and be responsive to the needs of the people we serve better. I think our time is running up. So some of the things that I've acknowledged is comprehensive sexuality education should be look all stakeholders' views. However, the issue of SRH varies across with different communities that require multi-sectoral approach. Fully equipped youth-friendly services, a major gap in Kakamega County, as Paul Odongo shares. Not all phone can access the link. We'll share the link on email as well immediately after this. Edwin Koga, Amazon Theatrics, okay. From those who have attended only, okay. As much as we insist on the consent age, every Kenyan is entitled to the highest attainable standards of health. How do we go about it? That one I mentioned, we'll have discussions on it in the coming session. Laws are not fair. The residents who have sufficient maturity as they understand what takes place around them, they are able to make decisions on their own. All they need is just to accent and to no need for parental consent, e.g. 15 to 17 years old adults. Those are dynamics that we have to go by the law, and also we don't want to be actually opposing the very constitution and the very laws that are guiding our conduct in this society. So we have to find the best approach to deal with them. Limited to HIV abstinence and related, not much. Lovely training session. A few comments from me are, let's engage the parents of these teenagers in our mentorship program and sessions so that they can understand what is really happening to their children and how to help them. Get more youth facilities to be able to provide the SRHR services effectively. Leila, you're right. This is a great issue and concern. I had tackled such issue when 2 girls of age 13 were getting molested by an old man. I could not go ahead with the legal authorities since they decided to handle it as villagers. The man paid some cash at the police station and they ended it like that. That is a great concern in our communities. And that goes to our moral values as a society. Do we do what's right or do we do what is convenient?
Amen.
Because if that is what we are going to do, then we are not helping anyone. And we need to approach it from a point of what is good for the society. Because as something that Leti was mentioning as well, you go even getting an abstract from the police to report a case, P3 form and all. Somebody wants you to pay 1,000 or 500 shillings. And at this point, you don't even have, you've not even had a meal in that day, but you have to pay them to do what is their responsibility. Is that what we're going to do as a society? So we need to look at all these dynamics. And the last thing that I'm going to say, as I give Leti, Salima, and Michelle the final chance to close out the session for us, is to ask us that our discussion has revolved around SRHR, the challenges, the key disparities that we are witnessing in our communities. And that sets stage for the work that we're doing. That is problem identification. So can you go back in your own, the next 1 week before we have the next session on Saturday, can you do a concept in just a brief problem statement looking at access to sexual reproductive health, from menstrual hygiene, sexuality, contraceptives, and even to people who are having difficulties in, like, let's say, sexual infertility challenges in your communities, because all that goes into sexual reproductive health. What are the challenges that are there? What are problems that are specific to your community? If I'm in Nairobi, probably the services are available. The challenge would be getting access to getting the parent to consent to it. And all those dynamics. There's somebody who is in a local community, there are people who are marrying them off at 12 years or 14 years in that setting. How do you look about that? The religious, the socio-cultural dynamics. Do a kind of a problem identification, a problem paper in terms of what are the challenges, how can we intervene, so that you already have started the program design, looking at how do we program as young people in SRHR, so that that sets the stage for our next session. And it also helps you reformat your plan so that when you are doing the work beyond this training, you've identified the problem, you've guided the journey and known how to address it, so that it's a more impactful process that is going to achieve the results that we all aspire and wish for. So thank you. Back to you, Michelle, so that Letty and Salima can help us close out as well. Then that would be it for me.
Thank you so much, David, for the wonderful comments. Thank you, everyone, for tuning in. There's a lot of comments that came in through the chat box. There's a lot of questions, verifications. Everyone was so involved in the discussion, and I'm really glad that we're all passionate about SRHR, and we are really hopeful and we're willing to impact the society as much as we can. So it's actually 11. This is the limit of the session. So I will quickly pass to our partners from Maristops, Letty and Miss Salima, so that they could give their final comments before we close up, and yeah, we could finish up. And before I hand over, if you haven't filled in the feedback form, kindly do it as fast as you can. So yeah, first I'll give the chance to Miss Letty to at least give us her final remarks as we conclude the session today.
So my final remark is that we are all now aware of the sexual reproductive health, right? And let us be advocates for this thing. Let us listen to women, men, and the complaints, and let us give them information. Let them also know these rights, because if I know the right and this, I know this is someone's right. Let me also help him to know that that is his or her rights as well. And we will be able to impact the society in a holistic manner. And I also want to encourage more of intersectoral collaboration when it deals to advocating for sexual reproductive health. We have a lot of small communities that are doing a good work, but they're not getting enough support and recognition. So if you come across any group that is doing this good job, let's try to bring them on board so that we have a larger network to drive the agenda. Otherwise, thank you.
Thank you so much, Miss Letty. Actually, that's the work that Ryculture is doing right now. We are really trying to bring in those who are doing so much work on the ground, and we're giving them as much support as we can so that they could improve their work and impact more youth. So next, I will give Miss Salima a chance to give us a few closing remarks before we conclude.
So for me, I say thank you very much to everyone who's attended this session. We look forward to further engagement. As Letty has mentioned, sexual reproductive health rights, even if it's focusing on youth and adolescents, it's everybody's responsibility, and we all need to do our bit in our small ways to ensure that adolescents and youth are able to access the services and information that they require. Thank you.
Thank you so much. Before we log out, we'd kindly ask we'll ask for your consent to take screenshots of the Zoom, of the platform, so that we could share it out in our social media platforms and tag you along as we share the work that we've been doing in Ryculture. So if you're comfortable and if you're okay, you could turn on your camera, or you could also turn it off as we take screenshots. So David, I hope you'll be doing that. David?
Try. Yes, I'll do that. So maybe you can just all turn on your cameras from wherever you are. I don't know why we are spotlighting you, Michelle. Okay. Oh, it's my view. Sorry. Good. So,
okay.
as
Thank
many
you
of more
so
of us
much.
who
Thank
can
you everyone
turn
for
over.
attending the session.
Yes, now that's okay. And there's one of our team members who has been here with us. Unfortunately, he's not been able to speak. Austin, maybe you could just say hi. I don't know if you're in a position to. Seems like he's not in a position to. So thank you so much, everyone. Thank you for being part of this session. And we hope we'll continue learning in the subsequent ones and make a difference in our communities together. Thank you and have a good afternoon, good weekend ahead.
Thank you too. Have a great day.